Assalamu alaikum. Good afternoon, everyone. I'm Mahmoud Abu Said, lecturer of orthopedic and spine surgery. Our next topic is lumbar disc prolapse or lumbar disc herniation. One of the oldest topics, yet a wide, broad topic. Even the first or one of the earliest papers was published in 1935. So we will try to be focused and exam or question oriented. Our learning outcomes are the following: epidemiology, classification, and clinical manifestations, coda equina syndrome, investigations, treatment, complications, and prognosis. Lumbar disc prolapse is more common in males with a ratio of 3:1. It is more common in the 4th to the 5th decade, with most of the cases involving L5S1. And this is in contrast to the degenerative disc disease, where the L4-5 is the most involved level. 95% of lumbar disc prolapse involve both levels L4-5 and L5S1. We can classify lumbar disc prolapse according to the location or the anatomy. And because of the unique anatomy of the nerve roots of the lumbar spine, this led to different nerve root affection according to the location of the lumbar disc prolapse. For example, in L4-5 lumbar disc prolapse, the paracentral lumbar disc prolapse cause affection of the L5 nerve roots, while the forelateral or the foraminal cause affection of the L4, which is the exiting nerve root. In general, the most common is the paracentral, and we have the central, foraminal, and extraforaminal lumbar disc prolapse. Well, according to the anatomy in 2012, Kepler et al. Mentioned that in lumbar disc prolapse, narrowing of the space available for the thecal sac can be due to, or he classified the disc prolapse into protrusion, where there is intact annulus, extrusion of the nucleus pulposus through the annulus, but the nucleus is still contained within the annulus fibrosus, or complete loss of continuity between the nucleus pulposus and the annulus fibrosus, and leading to sequestration of a free fragment. So what are the clinical manifestations? We should here mention that one of the most important manifestations is asymptomatic, and that the lumbar disc prolapse can be accidentally found on MRI. While the most common symptoms are axial pain or low back pain, which can be discogenic or mechanical in nature, and radicular pain, which is caused by nerve compression. We can call it radiculopathy. When it is affecting the sciatic nerve, we call it sciatica, or femoralgia in case of femoral nerve affection. This radiculopathy usually is worsened with sitting, flexion, coughing, and sneezing, or the positions that increase the intrathecal pressure. Some patients might present their first presentation with coda equina syndrome, and we will talk about it in the next slide. Examination. We do examination of the lower limb, neurological examination, motor, sensory, and reflexes, and the provocative tests. Coda equina is caused by severe compression of the nerve roots, the lumbar nerve roots. Many causes, most commonly acute lumbar disc prolapse, any mass occupying the thecal sac, or fractures can cause coda equina syndrome, but the most common cause is acute lumbar disc prolapse. The most common level is L4-5. It's more common in males in the 4th decade. Patients present with severe agonizing back pain, severe leg pain with or without lower limb weakness, which can be unilateral or bilateral, saddle anesthesia with bowel and bladder dysfunction and impotence. In this case, urgent MRI should be done and urgent decompression should be performed within 48 hours. This table shows the nerve root distribution and innervation of the lower limb. We can see that there is some overlap between L3 and 4 regarding the knee extension, L4 and L5 in ankle dorsiflexion. But we can roughly mention that L2, 3 are responsible for hip extension and hip flexion L1, 2. The ankle dorsiflexion, mostly L4, big toe dorsiflexion L5, and ankle plantar flexion S1. The provocative tests include the most common and the most important test is the straight leg raising test. It should be done with the patient supine, and it's a passive test, not an active one. The contralateral straight leg raising test, you raise the other lower limb and the patient feels pain on the ipsilateral side of the lumbar disc prolapse. The C sign, when you do ankle dorsiflexion, this increases the pain. The bowstring sign is the compression of the popliteal fossa. The pain increases. Kernick test, it's done with the knee flexed, hip flexed and knee extended. And the Nafstiger test, investigations. We usually do X-rays, CT, and MRI. The X-ray shows loss of lordosis, loss of disc height, and spondylosis. MRI is the most sensitive and most specific. It is the test or the investigation of choice. It helps in detection of level and the site of the disc and helps in preoperative planning. MRI can be done with contrast in case of revision surgeries to help differentiate between the recurrent lumbar disc prolapse and the fibrosis. CT was thought to be inferior to MRI in lumbar disc prolapse detection. But according to the NASS, CT myelography is now considered a very good alternative to MRI, especially in cases where MRI is unavailable or not possible with patients with pacemakers or cochlear implants, and when patients are excessively uncomfortable, those claustrophobic patients or those having intractable back pain and cannot stay still during the MRI examination. Now we move to the treatment of the lumbar disc prolapse. 90% or even 95% of the patients improve with conservative management. Rest, lifestyle modification, non-steroidals, muscle relaxants are the first and the most important line of treatment for most of the patients. Physical therapy can usually be combined with medications. In case of failure of conservative management and physical therapy, we can move to the second line of management, which is the selective nerve root injection with steroids for radiculopathy. So when do we do surgery, or what are the indications of operative management in lumbar disc prolapse? The following: persistent disabling pain more than 6 weeks, failed conservative management for 3 to 6 months, neurological affection in case of lower limb weakness or sensory affection, and coda equina syndrome, which is considered an emergency and needs urgent decompression within 48 hours. How to do it? You can do it either open discectomy, microscopic discectomy, or using the endoscope. And regarding the technique, you can do laminotomy or fenestration, hemilaminectomy, and in rare cases, we'll need to do laminectomy or wide decompression facet to facet. In 2017, Abou et al. Published a paper, Predictors of Improvement in Low Back Pain After Lumbar Decompression Surgery. And he mentioned that the preoperative higher leg pain, severity, better mental health status, shorter symptom duration, younger age, increased preoperative physical activity and severe preoperative low back pain yielded successful outcome after discectomy. And surprisingly, the presence of motor deficit, the level affected, or the side of the herniation, the gender, and type 1 modic changes were not found to affect postoperative outcomes. What are the complications of the lumbar disc prolapse surgery? The most common complication is dural tear, and this needs to be either repaired intraoperative or if irreparable, water-tight closure of the wound should be done. Recurrence is the second most common. Discitis happens in 1% of the cases. A very annoying complication might need a redo surgery. A rare complication, but a catastrophic one, is the vascular injuries and chronic low back pain or failed back syndrome in case of decompression leading to instability, and this will need to later on fixation. As we mentioned before, 90% of the patients will have improvement of symptoms within 3 months with non-operative care. The size of the herniation decreases over time, especially in sequestrated discs. They have the greatest degree of spontaneous resorption, and this is done by the macrophage phagocytosis mechanism. The treatment algorithm. Any patient presenting with acute symptoms suggestive of lumbar disc herniation should be properly examined. If there is any of the red flag symptoms, then we should check for the bowel and bladder habits, the saddle anesthesia. If present, this is suggestive of Coda equina syndrome, and emergent or urgent MRI should be done, and urgent decompression should be done within 48 hours. If there are no signs or symptoms of Coda equina syndrome, so an elective CT myelography or MRI should be done, and then the patient should be clinically assessed for having surgical interference or just monitoring the symptoms and considering other causes. If the patient is presenting with acute symptoms suggestive of lumbar disc herniation, but there are no red flag signs, then conservative management is the management of choice. Non-steroidals, muscle relaxants, opioids, some cases steroids are given and follow up in 1 to 2 weeks for the degree of the pain. If the pain is still there, nerve root injection and epidural injection can be considered. Otherwise, continue for conservative management and consider physical therapy and manipulation. If improvement happens within 6 weeks, then we monitor the patient and follow up. If no improvement, we go for elective MRI or CT myelography. Thank you for your attention.